Spain is a lot different from other countries because Spanish legislation allowed for an anonymous egg donation in the 80s, and Spanish legislation allowed for genetical testing of embryos of patients in the 80s. So when you perform this kind of treatments since 30 years, you have the biggest, the longest, and the best experience. So this is why Spain became a hotspot, because of the legislation and because of, it's like learning by doing. The more doctors perform one kind of treatment, the better we are getting. On the other hand, we are allowed to treat patients here until 52 years old. So, there are some European countries where you hear, oh my God, you're in your 40s, you are old. We do not discriminate patients because of their age. We treat you until you are 52. So between 30 and 42 years old, majority of patients that we have are coming here for IVF, own eggs, and PGDA. We perform a lot of genetical testing cycles to give an answer for recurrent implantation failure or recurrent miscarriages. And from 43 years old until 52, majority of patients that we treat are for an egg donation. We also treat patients, single women with the donor sperm, as well as lesbian couples. Yeah, for a patient who's coming abroad, the biggest problem is the logistics. They quite often ask me, do we have to stay here like 2 weeks, depending on our cycle? And then they start calculating, their medication plans with their natural cycles. And then we say, listen, no. Reproductive medicine does not have to do anything with natural cycles. And sometimes it takes us a while to convince patients that we have higher success rates in artificial cycles rather than in natural ones. So this is the step number one. And the step number two is we can design a medication plan, a cycle for you according to your free days, your vacation. So this is not a problem at all. And you just have to stay here for a week, for 7 days time, where we will do egg retrieval, fertilization with your partner sperm or donor sperm, and then the transfer. So basically we try to convince patients that you are flying here for a treatment because we are in the most advanced European Union country for IVF treatment. But on the other hand, you are flying here for vacation. You see how, beautiful, sunny Spain is, the beaches that we have. You're coming here to relax. And, in the meantime, we will work a little. So your body will be prepared for an egg retrieval or for a transfer. And the procedures that we do are short, are 10, 15 minutes procedures. So basically, you're coming for a procedure and 1 hour, 2 hours later, you can walk out of this office and, have lunch at the beach. When we have patients in their 40s, we have to explain them what is ovarian reserve and what are inclusion criteria for an IVF cycle. The answer is very straightforward. We have to take into consideration 3 A's: your age, your AMH, and your antral follicle count. Your AMH, it's a very good diagnostic factor that tells us the quantity of eggs, how many eggs we are going to generate. When we have somebody with an AMH more than 2 nanograms per milliliter, it's a very good ovarian reserve, and in the middle dose antagonist cycle, the patient will generate us 15-20 eggs. If AMH is between 1 and 2, it's a diminished ovarian reserve, and the patient will generate us 10-15 eggs in a middle dose antagonist protocol. When your AMH is under 1, you have low ovarian reserve, and things are getting complicated here. Your age, it's super important, because in different age groups, people generate different number of good quality eggs and good quality embryos. Means when we are having somebody who is 35, 36 years old, this patient will have 50-60% of embryos which are healthy, which are genetically normal. Between 38, 40 years old, we expect 30% embryos genetically normal. At the age of 42, we expect less than 10% of embryos which are genetically normal. So, taking into consideration just your age and your AMH, we know how many eggs will you generate and which percentage of them has a chance to be healthy or not. So you can imagine, if we have somebody with AMH 0.7, means low ovarian reserve, and 30 years old, she has 70% of chance that one of her few eggs will be healthy. When we have a lady over 40 and AMH 0.7, we have 20% chance that one of her few eggs will be healthy. So sometimes miracles happened, and not long ago we had a lady from Germany. She was 42 years old. Everybody gave up on her, and she had 13 eggs, 3 blastocysts, and 1 healthy. So you cannot imagine the pressure that we doctors have when we have to transfer this embryo. When we get patients after unsuccessful cycles in their home countries, we explain them the statistics, the numbers that I just mentioned, and we ask patients if they want to try with their own eggs, knowing that they have diminished or low ovarian reserve and low euploidy rate, means low number of genetically normal embryos, or not, or they want to go straight forward for egg donation. Of course, if somebody has good AMH and is over 40, will generate us more eggs, there is a higher probability that out of 20 eggs, we will generate 1 healthy embryo. So it's a lot easier to work with a patient with advanced maternal age and higher AMH than patients with advanced maternal age and lower AMH.